Next slide, Alex. So before we get into our program, we have what we call a few community agreements. That is, we ask everyone to keep your microphones muted. We ask you not to take photos of the screen, simply because there may be people who are joining this event who may not want to be recognized outside of this environment. And we need to respect that. We also ask that you use the chat box to share questions or comments, and we ask you to be respectful of everyone, even if you disagree. And we will use the chat box at the top right hand of the screen for your questions. Please leave your questions there. If you want a question directed to a specific person, please direct it, or just be a general question. Then our presenters can just open up and present and answer the question. We will try to share the slides and the recordings with anyone who requests it. But generally, I probably will just send you guys an email afterwards with a PDF of all the slides and a link to the recording as a YouTube file. Okay, next slide, Alex. So initially, our first presenter is Octavia Lewis. She's a transgender health coordinator with Montefiore Health Systems. Octavia is an African-American woman of transgender experience living with HIV. She is also an activist and advocate, humanitarian, mother, and scholar. Currently, she is the transgender health coordinator of Montefiore Health System and is focused on the healthcare needs of the transgender, gender nonconforming community. Octavia is active in many boards and organizations, including the National Advisory Board member of Positively Trans, PWN USA, as an advisory board member for Center of Excellence USCF, and the Bronx TGNC Collective. She holds a master's in public administration and is currently enrolled in a doctoral program. Community members, I'd like you to welcome Octavia Lewis. Octavia.
Hi, well, good evening, ladies, gentlemen, and non-binary people. As was stated, my name is Octavia Lewis. I am a proud Black woman of transgender experience that is living with HIV. Again, keyword living with. Um, what comes to mind when we talk about the disparities of our community, particularly Black and Brown people? We talk about, I guess what needs to be talked about is the disparities that our demographic or our race actually face. And just me quoting from an article that was published in JAMA, we have to understand the underlining causes of health disparities. They are complex. They include social and structural determinants of health, which include racism and discrimination, economic and educational disadvantages, healthcare access and quality, individual behavior, and biology. So, with those things being said, when we talk about, or when I acknowledge people of trans experience, we have to also realize that we don't have equal protection under the law in every state in these United States of America. So that plays a factor in the disparities that we face as well. Get out, Nina. Sorry about that. Um, and I don't think that that is something that, again, people take the time to talk about or even discuss. And when we talk about the disparities, especially from the healthcare industrial complex, it was only a month and a half ago when an article was released from the Franklin County Department of Health in Ohio, which stated what black people should not wear. Like we should not cover our face with red or blue bandana, which that could be associated with gang affiliations. They were telling us all the things that we should not be doing versus saying, well, we know that these stereotypes are out there. And we would not want anyone to be put in an unfortunate situation. But instead of having a conversation with their community that they serve, it was like they were vilified or again, not looking at it from a humanistic standpoint, telling people that, again, these are things that you should not do, versus giving people clear and concise instructions on what they could do to save their lives. Um, an Ohio GOP state senator, Steve Hoffman, who stated maybe African Americans didn't wash their hands, wear masks, or social distance. But I also want people to take into consideration, again, that none of that was from the CDC, none of that was from the NIH, none of those organizations, but he felt the need to ask or state that maybe we had these higher rates of COVID-19 infections because of those things. So again, that spoke a lot to what his perception was of our community. So moving again, we talk about why things happen in our communities, but we never address issues that systemically happen to our people, such as redlining and urban blight, those things which forced a lot of brown and black people to live in urban areas that were close quarters. So again, when we think about how people live on top of each other in this city, of course things were going to disproportionately impact us because of our surroundings, not because we were any careless than anyone else, but because we do have certain things that are stacked against us. Anton, are you still there?
Yeah, I'm still here.
So yeah, so like those are just some of the again the reasons why again I think we should be having conversations with our community to again have the conversations with us, not speaking at us. As a health coordinator for the transgender program at Montefiore, that is one of the things in which, again, we pride ourselves in doing. Is again asking questions that engage the community, finding out what their needs are, not telling them what we feel is best for them. And I can honestly say, being in this environment at Montefiore has been one of the best decisions that I have made. Is it a perfect environment? No. But it has allowed me um, the opportunity to, again, bring up certain issues from the community so that they can have someone that is not only in the healthcare profession, but also is a member of the community in which they are serving. So, again, my name is Octavia, and I thank you all for allowing me these few minutes to, again, speak to you about the disparities that our people face.
Thank you very much, Octavia. I just want to throw maybe a couple of questions at you. You've spoken openly often about living with HIV.
Mhm.
Can you share with us what is that like for you as a Black trans woman, and what is that like? How has that impacted your mental health? What is that? What has it done to you as a person?
That is a um, not only am I all those things that you eloquently listed, I am a mother. I am a mother of a 6-year old, and I have also a foster son that's 6. So, yes, I carry a lot of burdens and a lot of weights being Black. Secondly, living with HIV. And third, the fact that I am a woman of trans experience. And understanding how all those intersectionalities are, important and are pertinent to who I am as a human being. There are plenty of nights that I cry myself to sleep because my emotional wellness is not always the best. Because not only am I worried about myself, I'm also worrying about 2 brown and black little boys, worrying about their safety, worrying about teaching them how to conduct themselves that hopefully will save their lives. Whereas I know my non ethnic counterparts, they probably don't even think about those conversations. So when we talk about mental health, or as I like to call it, emotional wellness, I do suffer from it a lot. And if I did not have close friends that I could confide in, I don't know where I would be because it is stressful. Because even though I'm an activist and an advocate, I understand that there are some people that look like me that would not spit on me if I was on fire. And like those are things that I have to acknowledge and those are things that I have to be aware of. But it doesn't change the fact that I am still raising a young black individual and I have to stand up and show up for for my child. So all of those are things in which I carry. Those are complexities that I would not wish them upon anyone else. But again, they're mine. And I just try to make the best of them that I can. So again, if it was not for friends, I don't know where to be honest.
Thank you very much, Octavia. Alex, next slide. Joining us this evening from the New York State Department of Health AIDS Institute is Johanne Morne, and she'll be co-presenting with Louise Square. Johanne Morne serves as the director of the New York State Department of Health AIDS Institute and is with the Institute for more than 12 years. The AIDS Institute was created in 1983 to coordinate the state's overall response to the HIV epidemic. While the Institute's broad mission includes hepatitis and sexually transmitted disease services, surveillance, drug user health, and lesbian, gay, bisexual, and transgender health and human services, Johanne's leadership advanced the state's Ending the Epidemic initiative and the hepatitis C elimination campaigns. Her direction of deliberations related to the undetectable equal untransmittable led the New York State Department of Health to sign on to the U equal U consensus statement. The NYS DOH was the first state health department to do so. Johanne serves as a board member of the National Alliance of State and Territorial AIDS Directors and as the board chair since May 2019. In 2019, Ms. Morne was appointed to the CDC HRSA Advisory Committee on HIV, viral hepatitis, STD, prevention and treatment. The CHAC advises the HHS Secretary, the CDC Director, and the HRSA Administrator on objectives, strategies, and this part is being blocked out. But ladies and gentlemen, I'd like to introduce you to Johanne and Louise. Johanne and Louise, over to you.
Wonderful. Good evening, everyone. I'm actually going to ask my colleague, Louise Square, to start out in our conversation, and then I will speak after that. Louise?
Hi. Again, my name is Louise Square, and I am the AIDS Institute first ever Health Equity Coordinator. And so I think it's funny. I was hoping Joanne would bail me out because Octavia Lewis stole a whole lot of my presentation with regard to health equity and health disparities. I was hoping she'd say, well, Louise is going to speak right now.
No.
But thank you, Octavia, for introducing the topic of health equity and health disparities. My job really is to work with the AIDS Institute to move towards health equity and to eliminate disparities. And we're working to that. We're committed to that. We're prioritizing that. But I just wanted to speak a little bit more about inequities and disparities because people kind of usually mix the two up. Disparities are very different from inequities. What we know about inequities is that they're unjust and unfair. The things that we're seeing in the media, the things that we're hearing about over social media, the things that some of the things that Octavia alluded to with regard to how we keep ourselves safe. When the pandemic first started, I remember the governor started talking about which of us were more likely to get COVID, people who suffer from obesity and from chronic diseases. And the way it was talked about initially, it almost sounded as though, if you didn't have those chronic diseases, if you didn't have those other factors that affect your health, you might come out better. I certainly don't think that's the way he meant it, but listening to that and understanding that people of color are more affected by chronic disease, more affected by underlying factors. And you had to think, why is that? What causes that? Why do more people of color have HIV, diabetes, heart disease, cancer, and those underlying factors that are now causing us to have causing COVID to have a disproportionate impact on us. And so when you start to think about that, we can't blame the victim. There are circumstances, like Octavia said, that precipitate those things. Where we live, how much money we earn, the education we receive, we know that it's not equal. We know that it's not just. The governor talked recently about how much money is spent on a person who is educated in an affluent community as opposed to a poorer community. And so we know that all of those things affect our mental health. We know that when people talk about us as less than, it affects our mental health. When we know that we're not afforded the same opportunities, it affects our mental health. And as Octavia so eloquently explained, when we started to talk about how to protect ourselves from COVID, that affected our mental health. I remember thinking to myself when they finally endorsed the idea of wearing masks, oh my God, what is that going to mean for us as people of color? Because people of color who wear masks or wrap bandanas around their faces are sometimes thought to be ready to rob a store or to get in some other mischief. I even thought about how does it affect us when they started with the plastic bag ban in stores. Obviously, we don't want plastic bags in stores, but if I'm walking in with a bag that the store didn't give me, how does that impact me? Are people looking at me thinking that I'm putting things in my bag that I didn't purchase because I walked in with a bag that was reusable and that I'm being told I should do? How does that impact me? And how do these things impact us overall if we have to think about them constantly in an unceasing way? And so with all of that said, we know that impacts our mental health. But I just wanted to talk to you a little bit about what the AIDS Institute is committed to. We are prioritizing health equity. We are prioritizing racial justice. And we've come out with statements recently, including one made by Johanne, to back that up. We're looking inward first to make sure that all of our staff are on the same page and that we are we're brought up to speed. We have the capacity to work with our partners to address health disparities and health inequities. And we've been doing that for some time. In fact, I was hired as the health equity coordinator just in October. Even though I've been doing health equity work for 15 years, I'm so proud to be able to represent the AIDS Institute as they move towards health equity and addressing health equity. And so over the last couple of years, we've done work to make sure that our staff has the capacity to work with our partners to address health equity. And that would include some of the things that Octavia talked about and how it affects the mental health of people of color, of LGBTQ experience, of trans experience. And so I think I'm going to wrap up with that since Octavia took so much of what I was going to say. But thank you. I appreciate that people are recognizing the social determinants and the underlying causes of some of the things that we are impacted with disproportionately. So, Johanne?
Great. Thanks so much. Thank you. And good evening, everyone. So it really, I'm honored to join you. I want to thank Antoine for the opportunity to be part of this discussion. And, you know, I intentionally didn't do slides. And I think that's because, you know, I'm sure all of you, like myself, we're looking at 2020 and we're shaking our head and saying, what is happening around us? You know, every morning I wake up and say, now, what is next? And, you know, speaking for individuals, across the state. So let me tell you a little bit about the AIDS Institute. The AIDS Institute is a center within the New York State Department of Health. And what we have the opportunity of doing is working across the state with many community-based organizations and partners so that we can ensure that individuals have access to HIV services, STI prevention and care services, viral hepatitis services, as well as making sure that we're partnered to address and respond to LGBT health and wellness, as well as drug user health. And in that capacity, certainly when in the moment of time that we're in right now, our responsibility has always been around looking at the ways in which we can provide impact and sustainable change related to the health disparities that are experienced in so many communities, and in particular, across Black and Brown communities. And so one of the things you may be familiar with as far as one of the shared outcomes that we have at the AIDS Institute is an initiative that we refer to as Ending the Epidemic, in which the intention there is to significantly reduce the number of HIV diagnoses in New York State, and that's by the end of 2020. And one of the pillars, if you will, of ending the epidemic is to ensure that we leave no population or community behind. And it has been said from the beginning that in order for us to say we ended the epidemic, it would mean that no remaining diagnoses would be seen in any one particular community. And so when we talk about that, of course, we have to have the conversation as it relates to health disparities, but even more importantly, as it relates to how do we achieve health equity? Because when we talk about the mental health of individuals who are living with HIV, what we have to talk about are all of the compounding factors that contribute to one's mental wellness and one's mental health. So Octavia and Louise both really, I want to build upon some of the comments that they made. And, one of the things that I want to say about COVID-19, this novel virus that came to the United States, and certainly for those of you that reside within New York, and especially in New York City, have been so impacted by. I have to say that my frustration level with the number of individuals that want to talk about COVID-19 and want to talk about the disproportionate impact that COVID-19 has had on Black and Brown people is so frustrating to me, because I don't understand why we would have thought that would not have been the case when the health disparities that individuals were experiencing were well before the face of COVID. My question when these conversations come up, or when I see the research around some of these, around this subject, is, but what steps had we taken as it relates to our response to COVID-19 that would have disrupted the disparities? And as Octavia talked about, understanding and recognizing and responding to the social and structural determinants of health that play a part in the disparities that people experience because of the lack of housing, because of the lack of nutrition, because of the significant rates of mental health, particularly as it relates to anxiety and depression, because of the social injustices, which I'll touch upon more in a moment. So, one, when we talk about any public health response, what we want to do is really, if we're intentional about doing something to impress upon the disparities that we know are within our communities, then we have to take the responsibility to understand the social determinants of health. One, to ensure that there's access to prevention, to ensure that there's access to testing, and to ensure that there's access to care as appropriate. Now, what's interesting with COVID, and I want to go back to the primary focus of this discussion of looking at the issue of mental health among individuals who are living with HIV, the very factors that allow us to promote prevention of COVID, in many instances, for some of our community members, intensified the opportunities to experience mental health concerns. When we talk about social distancing, so many of our members depend on the opportunity to interface with providers, or the opportunity to to be able to engage in a support group or in any support service. 2, the mask, as was discussed by both Louise and Octavia. 3, sheltering at home. Well, you can only shelter at home if, in fact, you have a safe, stable, and supportive home to shelter in. All of these things contribute, according to the many individuals that I have spoken with, to the level of anxiety and depression that people have experienced. The social injustice, I'll build on the conversation that's already started. Certainly, as many of us, all of us, witnessed the murder of George Floyd over and over and over. For some people, what they saw in that was their own self or the persons that they love. And so as we see the protests that are happening today, and as we have the conversations about racism, both structural, social, we have to take into account the impact and the history, the personal experience and the history of trauma that people have individually experienced and communities have experienced. The social justice, the institutional racism, in and of itself, has contributed to the anxiety and depression that people experience. And even though, as we look at the protests, and we're proud of the fact that we're having these conversations and we're increasing in our opportunity to hold one another accountable, there's anxiety even within that. Because is this going to be a moment in time, or is this going to be a moment of change? What I know is that as we continue to move forward, in the title we talk about COVID-19 and beyond, what we have to do as providers and as community leaders is we have to ensure that we're creating the spaces where people can feel safe to talk about their trauma, to talk about the triggers that have happened for any of us, to talk about the post-traumatic stress disorder and the PTSD. For many people living with HIV, particularly among our individuals who are long-term survivors, the correlation and the alignment and the experiences of the same feelings from 30 plus years ago when HIV was once the death sentence to what they witnessed with COVID, the stigma, the discrimination, the lack of understanding, even the garb that we have to put on in order to provide testing. All of this, for many people, triggered past hurts, contributing to today's impact on one's mental health. And I encourage us to consider as a platform and look at how we integrate into the services we provide to people the use of trauma-informed care. It's one model. There are many other models as well. But at least to engage in the conversation and our planning as we look to how we provide support to individuals who are living with HIV and who are experiencing mental health concerns due to COVID, due to the systemic racism, due to other factors in their own individual and personal lives. How do we create the spaces that will allow people to be able to heal, to be able to speak, and to be able to create a plan for themselves so they can move forward in a way in which they feel empowered to live their true life? Thank you.
Thank you very much, Joanne and Louise. I am thinking that just quickly to ask you guys to respond to a construct or a thought that how do we interrogate and arrive at opportunities or solutions to address the combination of both mental health and HIV, especially given the circumstances and the environment we are living in. And maybe Octavia might want to jump in on this before we go to Dr. Glover, because I'm thinking, Joanne and Octavia and Louise, I'm thinking that our current environment, pre-COVID, some in our communities were struggling already with their mental health, living with HIV. COVID happened, it placed many people in isolation, and the social distancing is not these are not something that we are accustomed to as humans. But then we've got now the unrest that comes up from the pent-up anger that many of our communities have been carrying because of racism. So how do all of these things then impact our mental health? And then we're still dealing with HIV. I don't know who wants to jump in quickly on this.
I'm sure. Well, as I've stated before, for many people, and I'll just keep it on the I, as a person living with HIV, I was fortunate enough not to have experienced what many of the heroes and sheroes that have passed before me experienced with the isolation of getting that diagnosis and people telling you that you can't come to their house anymore, you're no longer welcome, or if you come over, you got to eat out of plastic plates and drink out of plastic, cups and things of that nature. But in my own experience, I could understand how they felt back then because I was not able to go and hug my friends or go sit down at the cafe to have a coffee or go about my daily routine or just be amongst people that I love. So like, even though I did not experience that, I understood in that moment what that might have felt like. And I know for me, that was not a good experience. So I can only imagine how those that had to experience that in the early onset of the epidemic and what they had to experience now, like how re-traumatizing that was for a lot of people. So for me, it was real, and there were a lot of people I know of that contemplated suicide because of the isolation, because they were like, I'm sorry, but I've never been accustomed to being by myself all the time, and that is hard, and it's still hard for because some of us don't know when we will be able to get back to that, or if we ever will get back to that to a certain degree.
Thank you very much, Octavia. And one of the things that jumps up when you're talking about that is the potential that now with COVID-19, they may develop shame and stigma that is related to COVID-19, but then that then also compounds and adds on to the already existing shame and stigma surrounding HIV. Johanne, do you want to jump in here quickly and talk about how all this stuff that's going on in our present community and environment impacts our mental health, especially for those living with HIV?
Sure, absolutely. So, I mean, I think that when you began to talk, one of the things you said is, how do we develop the spaces or the areas in which we can respond to individuals? And the first thing that I want to say is, we have to talk to the individuals that are having this experience in order to create the spaces that are responsive to people's needs. Right? I can make assumptions about what I think an individual may need, but I need someone with the lived experience to help us create the proper space and the proper response. Now, as it relates to mental health needs, yes, of course, for individuals living with HIV as it relates to the purpose of tonight's discussion. But in general, the first thing that we want to do, which is one of the main challenges in a social determinant of health that has to be addressed, is we want to ensure that there are support systems in place for individuals to be able to discuss the feelings that they're having and be able to have access to the resources and whatever interventions are needed in order for them to be able to receive relief from the overwhelming emotions that they may be experiencing. Because that overwhelming emotion may prevent an individual from doing some of the key things that are necessary in order to maintain their health, such as adherence to medication, such as attending doctor's appointments, such as doing the lab work. So, I understand that in life, as we are presented with a number of challenges, we oftentimes have to try to manage things simultaneously. But what I want to stress in this conversation is that in order to be able to face those challenges and gain relief from some of those experiences and feelings, we have to ensure that the systems are in place and that there is access to the support that people need by people who are representative and look like the communities in which we're trying to serve.
Thank you, Joanne. And you're actually pointing to something that may require a whole new other forum and discussion about access to people who look like us, who represent us, and who are able to advocate for us. And that may require a whole other conversation. But thank you very much for that, Joanne. Octavia, thank you for that. So now I'd like to move on and introduce Dr. Karrin Glover. Dr. Glover is the Director of Adult Behavioral Health at Montefiore Medical Group. She is a board-certified physician who specializes in psychiatry and teaches stress-reducing mindfulness skills that increase professional and personal success. Born in the Bronx and raised in White Plains, New York, she spent the greater part of her adult life following her interest in science, health, and improving life for women and the underserved. She contributed to various media outlets on a range of topics related to mental wellness. Dr. Glover used mindfulness-based techniques in both her psychiatry practice as well as her career coaching for professionals. She's the Director of Adult Behavioral Health at Montefiore Medical Group and is an Assistant Professor of Psychiatry and Behavioral Sciences at Albert Einstein College of Medicine in New York. Community members, I'd like to introduce you to Dr. Karrin Glover. Thank you very much, Dr. Glover. Over to you.
Hey, hi, everybody. I see that, yes, I was born in the Boogie Down, and that's where I work. So my name is Karrin Glover. I put together a wonderful slide set and sent you the wrong ones. So yes. So I apologize. When I tell you this pandemic and racial trauma just will not let me be great, I hope to shine in other ways right now. So in any event, we can, I'll give you an outline of what I wanted to talk about and what I plan on talking about. And we can still use some of the slides, just not all of them. So I'm on my toes, y'all, on my toes. So, all right. So essentially, let me introduce you to the work that I've been doing and who I am. So I was born in the Bronx. I am related to people who have survived HIV. I am related to people who unfortunately did not survive. I have people who in my family who have struggled with substance issues, incarceration, essentially what we call social determinants of health. We are Black people who are the descendants of slaves. We are Black people who have survived multiple things. And so I think what I hope to achieve during this presentation today is just a sense of overall hope that we are the children of those who have survived. So let's just start there. So next slide. And we're actually, if we can go to actually slide number 8, which is the one I want to start with to talk about my 7 years working with folks who have HIV. I want to talk a little bit about depression, anxiety, cognitive function, and trauma. And then I'm going to move on to talking about COVID, and then on to racial trauma plus COVID. Okay, so you know what? This is not the slide that I was looking for. So why don't you just put my picture back and we're going to take it old school. I'm going to do it off the dome. There, okay. All right, yeah, okay, there we go. That's fine. The things that I wanted to talk about are that folks with HIV are sometimes at much higher risk for depression. The rates are anywhere between 36 and 42%. Folks with bipolar disorder are almost 2% of all psych outpatients. The biggest things that we deal with when we are talking about HIV, especially in New York, are depression, anxiety, substance use, and as people live longer and longer with the virus, we're talking about brain health. So things that I learned in the course of my work in HIV, I learned to think in terms of a full history where I ask people about their childhood, their exposure to trauma, and how much they have managed to recover from their trauma, right? Because one thing I've realized is that if a person has not gotten treatment for what happened, the multiple adverse events that they overcame in childhood, chances are some of those things, there are remnants of those things in their adult life that might be hindering their ability to live a happy, healthy life. And so we're going to talk about the extrinsic forces, the outside forces that affect our mental health. But right now we're talking about the things that are within us that hopefully we can have control over. So again, I'm thinking in terms of what substances this person might be using. There's no judgment about who gets high and who doesn't. It's more about what does this substance do for you and how is it impacting your health. Right. So from there, the next part of my approach is to essentially take into account what have you tried in order to deal with your depression? What has failed you? What could work this time around? We're thinking through medications. I'm thinking about what kind of therapy can be useful to a patient. And then I'm looking at anxiety and I'm thinking through what this person has tried, what has not worked or worked in the past, and what could help. So I'm wondering if anybody on this call has ever tried mindfulness. I know that in the Black community, often we look at mindfulness so just leave me a message in the chat if you don't mind, or speak up by any means and just let me know if mindfulness is something you have tried, because that is something that we have embraced at our sites. Okay, so ACLU person has been using mindfulness lately, which is wonderful. Lawrence has tried mindfulness. So that's something that we are assessing. Hey, Larry. So we are, when we do our assessments with our patients, we are sitting with them and actually acknowledging when anxiety and depression have become overwhelming and saying, in between visits, how about we try these exercises? And if you feel too self-conscious, I'll do it with you right now. And so we are embracing not only medications, not only psychotherapy, but also mindfulness as a way to control anxiety and to control depression symptoms. So I'm going to ask that our slide person kind of speed ahead. There's a section of my presentation on cognitive function. Would you mind pressing ahead? Thank you. All right. So you're almost there. Okay, there. So, yep, keep going. And we should get to cognitive. Yeah, so stop. There we go. Okay, risk factors for neurocognitive disorders. Because here's the thing. One thing nobody tells you about depression, often in our community, when it comes to depression and anxiety, we just say, take a warm bath and pray, right? And stay away from medication and just wait till it passes. And so we know that for lots of people, a depressive episode or significant anxiety, it'll probably resolve in a year. But in that year, what is happening to your brain on depression? What is happening to your brain on untreated anxiety? And the answers we've gotten back are when somebody goes without treatment, and I'm not talking about medication necessarily, but when somebody goes without any kind of treatment and their depression goes on and on, they are at higher risk for cognitive problems later. They're at risk for a more difficult to treat episode of depression in the future. So we know that if somebody has a broken ankle, we would never say, you know, if you just prayed on it and took Epsom salt baths, this would go away. And if you demonstrated more faith, this would go away. We would never say that to somebody who had pancreatic cancer. Forego all treatment and just sit in prayer. We might say do both, right? Pray and go to the doctor, or pray and I'm, you know, go see your herbalist or go see somebody. But we would say probably get help. So the idea is that with depression, get help, whether it's psychiatric or simply showing up for therapy, because we know that therapy has an effect on how the brain is wired. So one thing that we also pay attention to is over the course of someone's life, what sorts of troubles has their nervous system endured? Untreated depression, substance use, HIV. We know that even when somebody is undetectable, has an undetectable viral load, they are sometimes at risk for memory problems in the future, because the virus, when the person first contracts the virus, it can live in the brain and the nervous tissue. So we pay attention to how often the person has had a CD4 count lower than 200. We pay attention to their nutritional status. Are they okay as far as their iron levels or B12 deficiency? We pay attention to what substances they might be taking. Next slide, please. And so we pay attention to when the person, and this, again, this is happening because people are living so much longer with the virus. We know that some people experience a slowing or difficulty with attention and concentration, and we don't always know what it's about. So we pay attention to apathy, slowed thinking, loss of balance, difficulty performing complex tasks, dropping things. And then as it may progress, we pay attention to whether they are having speech problems, incontinence, things like that. So next slide, please. So we do some testing. And so in approximately 1/3 of my patient group, I had folks who had cognitive issues, and I really had to wrap my mind around what I thought had previously been depression, and had to say, you know what, I think this might be something else. But the first thing I had to do was adequately treat their depression, right? Because I don't want to mistake one for the other. I want to make sure I have maximized all areas of treatment. Next slide, please. And so this is what we call the Montreal Cognitive Assessment. This is a tool that we use to assess memory, concentration, what we call executive function. And so for some people who have been positive for a very, very long time, and when I say a very long time, I mean 30 years, I am paying attention to how well they can follow the directions, how well they can retain information. And over time, I think through whether medication could be helpful for this person, what needs to be done. And again, this is actually one of the most hopeful areas of our work. It's because we know that people are living longer and living healthier with HIV. And if they're coming to me for treatment, they're probably interested in staying well. So when I do these tests over time, I look for ways to intervene. Next slide. So I pay close attention to how this person is doing, whether there is depression. If it's depression, how much can I treat it, and how can I maximize treatment? And then I want us to go, actually, you can go back to my photo, because I want us to talk a little bit about COVID and keeping track of how we're doing in the time of COVID. So if you get a chance, you can take the slides down and just go back to my photo. And I want to describe how we at Montefiore are trying to create access for people to get the care that they need. Is Alex still there? Alex? Can you just go back to, okay. All right, awesome. Thank you. Yeah, you can go, my goodness. So yeah, you can keep that there. Thank you. So one of the things that has been helpful to us has been learning that that social distancing has worked, that the HIV community, initially we were in the medical community, we were very, very frightened about how people were going to fare. And now we know that lab work is being done as our sites reopen, that people are able to get their labs done, probably not as frequently as usual, but they're still able to get them done. And that in a time of crisis, the insurance companies are allowing for a 3-month fill, so people don't have to go to the pharmacy as often. Alex, can you go back to my photo? Because I don't have any more slides to present. Okay, thank you. Y'all, I do apologize again for sending the wrong slides in the night. So in any event, I wanted to make sure everybody's aware, because you talked about access to treatment that is sensitive, that is competent. So one of the things that I've been recommending to a lot of my patients is the National Queer and Trans Therapists of Color Network. They have a website. I will send you my new set of slides. And so all these resources are on there, but this is a way to find a national directory of queer and trans therapists of color. And it's a beautiful way to connect with therapists who have done the work, who know the population and who know the needs, and who are ready to listen in a way that is non-judgmental and not biased. Also, there's an organization out of California called BEAM, B like boy, EAM. BEAM is doing wonderful work around caring for gender non-conforming people, the gay, the trans populations around the country. And they're doing amazing work from an activist standpoint. So at Montefiore, I just want to give you a sense of what's happened in the time of COVID, that the visits are virtual, they are not in person. So they are over the telephone and they are through video. If you connect with a primary care doctor or with one of our psychiatry clinics, you will be connected to a therapist who will see you by phone or by video. And we do some screening for mental health disorders, and that we are trying to practice in a way that is as safe as possible. So that's the perspective with COVID, and just understanding that we're going through a time of loss for all of us, therapists included, right? And that this trauma of this overwhelming virus hitting our population is something that we are grappling with very gradually, but also very deliberately. And then on top of that, we are trying to take care of people in light of racial trauma. We know that with every police interaction that results in murder or harm, we know that the mental health of Black people suffers. That is documented, that is in the literature, that's also in the presentation that I will mail you. And we know that that has to be dealt with in a way that is, again, considerate of our history and considerate of the circumstances that we face on a daily basis every time we leave our homes, or in the case of Breonna Taylor, not leaving our homes and still ending up undergoing major trauma. So what we're trying to do is, with our patients, engage people about what's happening with not only the virus, not only the pandemic, but also around racial trauma and understanding that all of that, facing discrimination in multiple domains of your world, work, family, neighborhood, can affect your mental health. So I'm just going to wrap up by saying that we've been emphasizing that this period is temporary, but deeply impactful, and that we are committed to helping our patients recover. We are emphasizing a sense of community by doing online groups. We are doing virtual visits with a patient base and a group of therapists who are of diverse backgrounds, but who are willing to, again, put in the work to investigate and interrogate their own biases, but also remain very, very helpful. We are emphasizing for our patients the importance of getting exercise, of doing yoga at home, doing mindfulness, and getting some exposure to sunlight, and again, maintaining community and even ritual, developing healthy rituals that affirm not only who you are, but also the future that you are trying to envision for yourself. So again, thank you so much for inviting me, and I apologize for my slides. I will send them to you, and I noticed there's some questions in the chat, so if we want to review those.
Yeah, so thank you very much, Dr. Glover, and we're actually a minute over. So for those people who understand and would want to remain, there's a question here. Is there a link between cognitive issues and dementia?
There can be a link. So for some people, when they're depressed, their thinking slows, they have difficulty with memory and concentration. We call that a pseudo dementia. We call that's like sort of a fake dementia, because we know once the depression is treated, they will probably fully recover and have their memory and their concentration intact. What we have found, though, is that for some people who have been dealing with cognitive decline because of the virus, that can be linked to dementia, and that there are stages for that. And it's usually not just dementia. Sometimes it's a movement problem. Sometimes it's a tremor kind of problem. Sometimes it's difficulty with coordinating movements, holding objects, things like that. But it's something that happens over time, like decades.
So you're saying that then you're saying that over time, somebody who's dealing with HIV can develop neurocognitive disorders. So is this related to treatment, or is it all in combination with treatment?
It's a lot of things. So I will give you the example of somebody who I saw for years. She was a 54-year-old at the time, nurse's aide in the hospital, and she had been positive for about 25, 30 years. At the onset of her virus, she was not taking any medications. She had gone on and off crack for a number of years. And so the combination of having used drugs and having gone untreated, she had not been on ARVs for about 10 years. Her nervous system had taken some hits, right? And so even though she was completely sober while she was getting treatment from me, she had been positive for so long and untreated for so long in the past that she had reached a point where she was not able to function very well at work. And she was starting to get feedback from her managers where they were wondering, like, what's going on with you? And so when she came to me, we did all the testing that I talked about. And then I put her on a little bit of Adderall, just a little bit of a stimulant that we normally use for ADHD. We treated her depression, we treated her anxiety, we treated all the things. The last remaining thing that made the biggest difference was putting her on a stimulant. And that has proven extremely helpful. This is a full-time employed woman, a mother of 3, a grandmother who is functioning quite well.
Thank you very much again, Dr. Glover. Any other questions? Anybody thoughts or comments? Okay, next slide, Alex. Thank you. So this is like I said, the 5th in our series. So we have a number of other discussion forums coming up in the next several weeks. Next week, we talk about being homeless and dealing with mental health. And then the following week, we talk about being incarcerated. Then we talk about eating and nutrition. Somebody's just joining us. Welcome, Tamika. We are about to come to the end of our program. Then we are going to be talking about behind closed doors, looking at the domestic and intimate partner violence. We'll also be talking about the elderly community, elderly and seniors. And then we'll be looking at what does the trauma of COVID-19 do to our mental health, and what does life look like for us afterwards. So this takes us all the way to July 23rd. So just look out. If you remember registering, you would have seen a list of all of the different events that we've got coming up. So you can still go ahead and register for them. All right. And once again, thank you very much, Dr. Glover. Thank you very much, Joanne and Louise and Octavia. I am so happy that you guys were able to join us and share with us some information and your knowledge. I think what is important also is what we talked about with Joanne and Octavia and Louise, is the social dynamics that are taking place and how they impact our mental health. So thank you again very much. And we will share the revised slides and this recording with everybody.
Thank you, Anton. And also, I would like to say, for those that are not aware of the ETE ending the epidemic, please look into that. And also, I want to give a special shout out to HIV Stop For Me, because that campaign has allowed for women with trans experience to be a part of that and to speak their narrative. So I definitely give a shout out to Mother Lamia. I give a shout out to Leilani, and definitely Giselle for being, as we call ourselves, the Real Housewives.
Thank you very much. Thank you very much, Octavia. All right. So we good, everybody?
Yep.
All right. Thank you again. Have a good night.
Have a good night, everyone.
Thank you.
Bye-bye.